Welcome to this Oncology Data Advisor interview, which we're holding today in honor of AML Awareness Day, which is held this year on April 21st. And I'm joined by our editorial board member, Dr. Tristan Knight, who's here today to share some insights on the evolving field of AML and messages to keep in mind for AML Awareness Day. Dr. Knight, thanks so much for coming on today.
Absolutely. Thank you for the invitation.
Absolutely. Looking forward to hearing your perspectives. So with that, I will let you take it away.
Thank you all. So, good morning, everyone. Where I am, it's morning. I'll introduce myself briefly, and then I'll kind of get into the topic. So, I'm Tristan Knight. I am a Canadian-born, American-trained pediatric hematologist-oncologist and transplant physician. I did my residency at the University of Hawaii, and then went to Detroit for my Hem-Onc fellowship. Toronto Sick Kids for my bone marrow transplant fellowship. And then I was in Seattle at Seattle Children's and the Hutch there for about 3.5 years before moving back to Hawaii, where I currently am, hence the aloha shirt. And I'm now working at Kapiolani Medical Center for Women and Children, which is my residency alma mater. So I'm glad to be presenting on this. So today I'm going to talk through a few different topics here. We're going to review the modern landscape of AML treatment, management, and emphasize kind of the evolving treatment paradigms because it's an area that's rapidly seeing a lot of improvements, which is great. I'm also going to touch on pediatric AML and bone marrow transplant and cell therapy for this topic, those being interests that are close to my heart. So, by way of background and overview, so AML, as I'm sure folks know, but I'll kind of go through things, is a clonal malignancy of myeloid progenitor cells characterized by the accumulation of undifferentiated or poorly differentiated blasts in the blood and bone marrow. The disease is driven by a multi-step accumulation of genetic and epigenetic abnormalities that impair normal hematopoiesis and enable leukemia cells to proliferate, self-renew, and evade the immune system. It's mostly a disease of older adults. Median age is diagnosis is about 68, but pediatric AML represents about a fifth of all cases, and also about a fifth of pediatric acute leukemias, and is biologically somewhat distinct and warrants different therapeutic approaches from that reason. So molecular heterogeneity underlies the diversity of AML. There are some common inciting events, particularly in genes that regulate chromatin modification and DNA methylation, DNMT3A, TET2, ASXL1. And the disease progress itself tends to be driven by secondary mutations as signal activating pathways. So FLT3, for instance, RAS, RUNX1, CPPA for transcription factors. And based on those mutations, the classification system, especially the European Leukemia Net system, integrates those abnormalities and mutations to categorize AML into favorable, intermediate, and adverse risks. And this stratification basically guides treatment, response, therapies, transplant decisions, and in some cases, maintenance therapies after transplant. So for instance, favorable risk categories would include translocation 821, inversion 16, NPM1 mutations without FLT3, or biallelic CBPA mutations. Adverse risk categories, things like complex karyotypes, TP53 mutations, FLT3 ITD with high allelic ratios, these things tend to upgrade the risk category, with the groups correlating with response to chemotherapy and long-term survival. So for adults, the classic approach has been in medically fit adults under around about 65 age. There's been standard induction therapy, which remains 7+3, it's called, 7-days-cytarabine and 3 days of anthracycline, usually daunorubicin or idarubicin. This background's been around for decades, and although we've been trying to improve on it, it really is kind of the backbone we build off of from that standpoint. Patients achieving CR, complete remission, undergo a consolidative transplant or make transition to high-dose cytarabine, depending on their molecular and cytogenetic risk factors. CPX351, daunorubicin, and cytarabine in a 5-to-1 ratio has shown some improvements compared to 7+3, especially in therapy-related or MDS-related AML. So for older patients or those who are not considered medically fit, the treatment is more difficult. There have been some advancements in that area, though, especially combining hypomethylating agents, so azacitidine or decitabine plus venetoclax, which is a BCL2 inhibitor, and that's kind of become a new standard. The Really, the gold standard trial there was the VIALE-EA trial, which demonstrated a markedly improved response rate and survival rate with azacitidine and venetoclax compared to azacitidine alone. And this combination tends to be used in older or less fit adults who cannot tolerate transplant or more intense therapy. Pediatric AML, again, a little bit different. It tends to be a cytogenetically different disease, biologically different from adults. It has fewer somatic mutations, but more often there are cytogenetic rearrangements, 821, inversion 16, and KMT2A being examples of that. Treatment in kids is multi-agent and it's quite intensive, in large part because kids can handle it, basically. They're generally fitter, they're fit in comparison to adults, and they have fewer accumulated side effects and toxicities risks due to their just general better organ function from their younger age and resiliency. And that approach includes cytarabine, anthracycline, and etoposide given in an induction and consolidation phase, and then transplant tends to be reserved for those with high-risk features, poor response to induction therapy or relapse disease. Key differences in pediatric AML from adult AML is that the cure rates are actually really quite good in kids, two-third cure rate roughly. The AML cells tend to be more sensitive to cytotoxic chemotherapy just because of their reduced mutation burden compared to adults. And there's more importance placed on longer-term toxicity. Obviously, treating an 8-year-old versus an 80-year-old, we care a lot more about the long-term effects. Novel therapies, including FLT3 inhibitors and gemtuzumab, which I'll come back to as immunotherapy, are being incorporated into pediatric trials. And those are being led by the Children's Oncology group, which is kind of the main cooperative body that we use in pediatrics to guide therapy. So I'll talk about targeted therapies. The landscape for treatment in AML has really improved dramatically in the last few years due to the approval of targeted agents over these, roughly the last decade, we'll call it. These therapies basically utilize our improved understanding of AML mutations and target those mutations either in combination with chemotherapy or as monotherapy in relapsed or refractory disease or after transplant as kind of a maintenance therapy. FLT3 inhibitors are probably the biggest category of that. So mutations in FLT3 are seen in about a third of cases, and they confer a poor prognosis. But that's a targetable mutation now. So midostaurin is the first example of that, the first generation FLT3 inhibitor, and it's approved for use in newly diagnosed FLT3 mutated AML in combination with 7+3 chemotherapy. And the RATIFY trial was that trial and showed a major improvement in survival. Gilteritinib, second generation FLT3 inhibitor, with activity against both ITD and TKD mutations. It was shown to work in the ADMIRAL trial and significantly improve survival compared to salvage chemotherapy in relapsed or refractory disease. Post-transplant maintenance with sorafenib, gilteritinib, midostaurin is currently under investigation. It's a bit controversial as far as how well that actually works. Some studies have shown that it works, some have not. I would say there's no real consensus in the field post-transplant. IDH1 and IDH2 inhibitors, mutations in those two genes produce oncometabolites that impair differentiation. So obviously that's a problem in AML where the issue is, they get stuck in that blast phase. And they're present in about 20% of AML patients. So ivosidenib and enasidenib for IDH1 and 2 respectively are oral inhibitors that promote differentiation of leukemia blasts. Both are approved for AML and now being used in combination with azacitidine in the diagnosed patients. The AGILE trial showed that ivosidenib plus azacitidine improved EFS and overall survival compared to azacitidine alone in IDH1 mutated AML. TP53 mutated AML is more complex to treat, often has a complex karyotype and may be seen in secondary AML or MDS, and it represents a very high-risk group with a poor outcome. There are a few drugs that are being investigated from this standpoint. Not great outcomes in some of these trials. There's one, magrolimab, which is an anti-CD47 antibody that helps with that, and ongoing trials showing some possible benefit with azacitidine. The menin inhibitor, such as rivimumab and ziftomenib, are in early phase trials, and those have shown some improvement in that standpoint. Menin is a chromatin regulator for leukemogenesis in KMT2A range and NPM1 mutated AML. So this is important because these tend to be heavily pre-treated patients who have this, and it's still being shown to have a benefit from that standpoint. Other agents we're looking at, I've mentioned venetoclax already. That's being combined with various regimens, possibly including the FLT3 or IDH inhibitors. Again, we don't know how well that actually works, but it's certainly a theoretical option. And then gemtuzumab ozogamicin is an anti-CD33 antibody paired with calicheamicin as basically an antibody drug conjugate, and that is being used in certain contexts and has shown good efficacy there as well. Transplant remains the cornerstone of curative therapy for most AML, especially the higher risk versions. Generally, the target being to do this in first complete remission, or certainly for relapse disease. Timing on this is hard. Obviously, you want to get the patients into relapse. You want to get the patients while they're in complete remission, but that can be a narrow window. So it's important to kind of start thinking about transplant as soon as the patient are diagnosed, so you have everything lined up so they can go straight into transplant without taking the chemotherapy, a big break there, which can allow them to relapse, and that is not optimal. Conditioning can be a complex question, especially in less fit adults or older patients who have comorbidities. So reduced intensity conditioning can be an option in those patients. Donor selection, with the advent of post-transplant cyclophosphamide, we're having a lot more options available for donors, with the haplotransplants becoming much more prevalent, much more common from that standpoint. Post-transplant maintenance, post-transplant relapse is a major problem and is probably the main cause of treatment failure. So maintenance strategies for that include the addition of azacitidine or decitabine after transplant for high-risk patients, certain targeted agents. I mentioned sorafenib and gilteritinib for post-transplant FLT3, and some agents are being looked at like venetoclax in clinical trials in the maintenance setting as well. These are all agents that are well tolerated, low toxicity, and are an option to consider post-transplant. The issue being, we don't know in many of these cases which patients benefit from this and which ones don't. And we also don't know when you can take that off. Is a year enough? Is 2 years enough? When do you take it off? And then are you going to see a relapse after that fact? And that's kind of an area of active investigation. Immunotherapy and CAR T in AML. So while immunotherapy has certainly transformed the landscape in other diseases, especially ALL, it's a challenge in AML. The key challenge here being a lack of antigenic target that's specific to myeloblasts. I'm going to spend a bit more time kind of going through this part because this is a major area of active interest and research as well. So I'll first note that we know that CAR T cells can work in AML because CD19-directed CAR T cells have been used in a very off-label way to treat AML that expresses CD19. So we know that can work. That's not common, obviously, but we know it works. The issue is that a lot of the blasts antigens that they express in AML are also expressed on hematopoietic stem cells or early multilineage progenitors. So that tends to be seen. They're often less expressed than in myeloblasts, but that certainly makes targeting them difficult. This is in contrast to things like ALL or myeloma, where targeting CD19 and BCMA respectively is really kind of a throwaway antigen, if you will. It doesn't really cause much damage if you get rid of it. Usually you can replace that with IVIG infusions and have not much in the way of long-term side effects. Whereas the antigens that we have on the myeloblasts, targeting those causes major long-term issues. So I'm going to walk through the main ones we target from that standpoint. So the first is CD33. That's seen in about up to 99% of AML. It's a promising target. It's present on the leukemia cells, including the leukemia stem cells, which are a main issue and cause sort of relapse. The inability to target those quiescent cells often is a sort of relapse. We also know that it works. Targeting it with gemtuzumab has shown great efficacy. The problem is it's also seen on hematopoietic stem cells, so toxicity is a major concern. Various constructs exist for this, and they are being utilized in that setting. And early trials have shown that there is efficacy in using these trials as well. Side effects tend to be manageable as well, things you'd expect, ICANS, CRS. But the patients, when they relapse, they tend to relapse when given this CAR T cell construct, which tends to, implies that there's some work to be done there, and there's probably antigenic escape happening. AML blasts tend to be more prone to antigenic escape than ALL cells are. CD123 is an option. About 3/4 of patients express this, and myeloblasts express this, found in various immune cells, but also on normal hematopoietic stem cells. Overexpressed, though, on AML cells, which makes it kind of an attractive target. The key challenge, again, same thing, is that it's seen on many healthy cells, including endothelial cells as well. And so damaging those causes blood clots and suppresses normal endothelial function, which is a problem, obviously. CD135, also known as FLT3. This is obviously an attractive target in FLT3 mutated AML, but it is involved in normal hematopoiesis and expressed on stem cells, but also in leukemic stem cells. So, it's one of those options that we have that is, risk-benefit, obviously. These mutations in AML cause the FLT3 to be constitutively active, which translates into a worse prognosis, hence the idea of targeting them being attractive. Preclinical work has shown this is effective in leukemia stem cell lines. And again, same issue really, is that the targeting of healthy stem cells by this FLT3-directed CAR is an issue. The CLL1 is also expressed on AML cells. It was obviously identified first in other kinds of malignancies, as well as on leukemia stem cells, and is responsible for relapse, but it's not expressed on healthy hematopoietic stem cells, which is, an attractive target. Expression tends to be on granulocytes, monocytes, and their progenitors. Again, that's ideally not something that we're going to be removing from patients. It also tends to be an issue because of the large, widespread amount of these normally expressed CLL1 on normal immune cells tend to have a more aggressive response with CRS and such. So the other options for immunotherapies, bispecific T-cell engagers, for instance, targeting 123 and CD33, being looked into as well. Again, less advanced than in ALL. We have things like blinatumomab. Checkpoint inhibitors also probably an option, but maybe more looked at as a way of reversing T-cell exhaustion than in the way it's used in solid tumors as a kind of like directly activatory thing. So what do we do with that then? So the approach we could use for CAR T cells is as part of a transplant conditioning regimen. So obviously the point of transplant conditioning is to wipe the marrow clean. So, if you think about it, giving a anti-CD33, for instance, CAR T cell to patients who are going to get a transplant anyways, wipes the marrow clean, it doesn't actually cause an issue. That's a good thing. You want that to happen. That's actually something that's being looked at in some trials is giving CAR Ts first. So despite some promising research in this area from preclinical and clinical studies, some challenges need to be overcome for CAR T cells to be used in this way, though. So we need to basically be using either myeloablative transplant or CAR T cells to deplete stem cells. It's also probably a good idea for these cells to have some kind of safety switch, because if these cells persist and you try to transplant a patient, for instance, that would cause graft failure, which would be unfortunate. The issue as well, CAR T cells require apheresis to occur and require patients to have collection of cells, which is an issue. The longer time between collection and manufacture can be an issue, and that is difficult because these patients tend to relapse aggressively, so that long duration tends to be a problem. So one could approach that, for instance, by doing upfront collection. But right now, this tends to be used in more of a relapse refractory setting where patients, have less time and have more beat up marrow, so it's harder to collect. So for this reason, research looking into universal CAR T cells is a promising and needed angle. The idea here being that you would use kind of off-the-shelf CAR T cells, potentially in AML. That would reduce time to transplant. It would also mean you don't rely on the patient's own marrow, which has been beaten up by the chemotherapy. And it would also decrease cost of production because, as opposed to being a bespoke thing that's being used in patients, it would be something that could be used for a larger population of patients, the same kind of product. I'll touch briefly on MRD, minimal or measurable, depending on who you ask, residual disease. It's a powerful prognostic tool in AML. Methods include flow, which is sensitive to 0.01%, quantitative PCR, which can look for fusion transcripts, or NGS, which can look down to the 1 cell per million level. So integrating those technologies into decision on timing around transplant and who to transplant can be helpful. Again, it's less mature than in B-ALL, but looking at that is something that we're actively working on. So I will just kind of wrap up there, and I'll go through some conclusions and future directions. So AML management has transformed into a genomically and genetically defined discipline where we rely very heavily on the patient's mutations to guide our therapy and the patient's prognosis. We're incorporating multiple targeted agents into frontline and into salvage regimens, targeting the mutations that are causing or driving the EML. We're expanding transplant eligibility and post-transplant maintenance strategies, again, through use of more haplodonors and the use of transplant post-transplant maintenance agents to kind of keep the leukemia in remission post-transplant. But again, there are many questions that are unanswered there. Immunotherapies, including CAR T cells, are emerging as a novel area of treatment. Again, it's a relatively immature area, but one that has a lot of very interesting, very exciting research happening in it. And then we're integrating the measurable residual disease into clinical decision-making around who gets transplants and time on transplants as well. But major challenges do remain here. Drug resistance, so AML cells developing resistance to the drugs. Certain mutations, especially TP53 mutations, are very challenging to target. And then post-transplant relapse as well is a major issue. So there's a sustained focus on these on clinical trials, biological discovery, and biomarker development that'll help address these gaps. So just to say basically that as we move towards more individual therapy, our goal is not only to achieve remission, but to provide durable curative strategies with acceptable toxicity across diverse patient populations, including pediatric, older, medically complex, and less fit patients. The latter categories being a major concern and an area of active research. So I will pause there and thank everyone for their attention and their interest in this important topic.
Yeah, thank you so much, Dr. Knight, for sharing these insights today. I always learn so much from your talks. It really covers so much of the evolving field of AML. So thank you for covering the challenges and future directions to look forward to. So appreciate your sharing your perspectives today.
Thank you so much. Thank you for the opportunity to talk.